Hello, my name is Gia Benno from the Louisiana Department of Health, Office of Public Health, Bureau of Family Health. Today, I'm going to talk to you about using the perinatal periods of risk, or PPOR, to analyze fetal and infant mortality in Louisiana. So what is PPOR? PPOR is an approach for how a community can investigate fetal and infant mortality. It allows us to use an analytic approach to identify gaps and disparities between groups in a population. And once we determine where there is excess mortality, we can use this approach to determine where to target resources for prevention activities. So this is what PPOR looks like. PPOR uses the birth weight at birth on the left-hand side of the screen and the age at death across the top to put all fetal and infant deaths into one of these four cells. And by comparing a target population to a reference population of infants with the best outcomes, we can figure out where we are seeing excess mortality. Each cell has a preventative action suggestion. Maternal health focuses on preconception health. Maternal care focuses on prenatal care and high-risk OB care. Newborn care focuses on perinatal management, and infant health focuses on the safe sleep position and environment. So first, I looked at PPOR in Louisiana as a whole. And this is using all Louisiana births as a target group and a white reference group. So for the reference group, I used Louisiana resident mothers who were over 20 years old and had at least some college education. And while there's no hard and fast rule about what cutoff in excess mortality is cause for alarm, we usually think of it as a doubling of the rate, or a 2 for maternal health and infant health, and a 1 for maternal care and neonatal care. So a 2 for the blue cell and the green cell, and a 1 for the pink cell and the yellow cell. So while there is some excess mortality when I used all Louisiana births, I then decided to break it down by race, comparing white births to a white reference group and Black births to a Black reference group. So here I compared Louisiana births to white mothers as a target group compared to a white reference group of Louisiana mothers with the best outcomes. And as you can see at the bottom here, there's not that much excess mortality in this group. Then I used a Black target group of Louisiana births to Black mothers compared to a Black reference group for the state of Louisiana as a whole. And as you can see at the bottom here, there's still not that much excess mortality. And this just shows the importance of looking further. So I could have looked at Louisiana as a whole and decided that there wasn't excess mortality and moved on, but that's far from the truth. It is important to look at a breakdown of regions of the state to see if there are certain areas of the state where we are seeing excess mortality, but not others. So I did PPOR phase 1 for all regions in the state. We have 9 public health regions. I then chose to follow up with PPOR phase 2 on the regions where we had the highest excess mortality for each cell. So for the maternal health, the blue cell, I focused on the HOMA area, which is Southeast Louisiana. For the maternal care cell, which is that pink cell, I also focused on the HOMA area. For the neonatal care cell, or that yellow cell, I focused on Monroe area, which is Northeast Louisiana. And for the infant health cell, or that green cell, I focused on the Shreveport area, which is Northwest Louisiana. So the first section I chose to focus on is the HOMA area, or Southeast Louisiana. So as you can see, there's a lot of excess mortality in the maternal health and prematurity cell, which is that blue cell along the top, and the maternal care cell, which is the pink cell on the side. And these are over the excess mortality cutoffs that I discussed previously, or a 2 for the maternal health cell, and a 1 for the maternal care cell. So for this area, I'll be talking about the potential to prevent fetal and infant deaths among those born weighing between 500 and 1,500 grams, irrespective of the timing of death, including fetal and infant deaths all the way through a year, as well as fetal deaths born greater than 1,500 grams, which is that maternal care cell. So first I looked at maternal health. The maternal health cell accounts for 52%, or about a half of the excess mortality in the HOMA area. And by decreasing the excess mortality in this cell, there's the potential to avert about 13 fetal and infant deaths annually. Next, I conducted a Kitagawa analysis to determine if there are too many very low birth weight babies being born in the HOMA area, or if there were too many very low birth weight babies dying. And I found that in this area, The problem is that too many very low birth weight babies are being born between 500 and 1,500 grams. And this is based on birth weight distribution, which is related to preconception health, family planning and intention, and selected risk factors. And as many of you know, this can go back to access to insurance and socioeconomic status. I then looked at some individual variables between the target group, which is HOMA area births, and the reference population of Louisiana mothers with the best outcomes. And this is data from the birth certificate. The target group had much higher percentages of Medicaid deliveries, mothers on WIC, mothers with previous preterm birth, which is expected because, as we know, if you've had one preterm birth, you're more likely to have a second one, diabetes prior to pregnancy, hypertension prior to pregnancy, and STIs during pregnancy. And we included STIs such as chlamydia, gonorrhea, syphilis, herpes, Hep B, Hep C, rubella, and toxoplasmosis. I then decided to break down that maternal health and prematurity cell into 3 groups. So all of these weigh between 500 and 1,500 grams at delivery, but I separated out to be either fetal deaths, neonatal deaths, which is those who live between 0 and 27 days, or post-neonatal deaths who live between 28 days and a year. And as you can see here, the excess mortality is in the fetal death section instead of the neonatal or post-neonatal section. And between that realization and the fact that the HOMA area also had high rates of excess mortality in the maternal care cell, I realized that I should look closer at fetal deaths in the HOMA area. So first I looked at overall fetal deaths in the HOMA area. And there were 66 fetal deaths greater than 24 weeks gestation and greater than 500 grams between 2016 and 2018. 28 of these were between 500 and 1,500 grams, which is the maternal health and prematurity cell, and 38 fetal deaths were more than 1,500 grams, which is the maternal care cell. When you combine the fetal deaths from these 2 cells, it makes up 55% of the excess mortality in the HOMA area. And if we could decrease the excess mortality in these 2 cells, we had the potential to avert about 14 fetal deaths per year. I also compared fetal deaths in the HOMA area to other areas of the state. The HOMA area has the highest rate of fetal deaths in the state. And while other regions had seen decreases in fetal deaths over time, the HOMA area had not. And actually, we saw a bit of an increase in this group area. So next, I looked at just the maternal health cell. So this is just the 28 fetal deaths that were between 500 and 1,500 grams at delivery. 43% of the fetal deaths were late fetal deaths, which is greater than 28 weeks gestation. And the rate per 1,000 fetal deaths and live births is higher in Black than white. The risk was also higher in women less than 20 than in any other age group of mothers. And you can see that there's a big decrease between that less than 20 rate and all other ages. I also found that rates were more than 2 times higher in women with private insurance compared to Medicaid deliveries. And the causes of death were unknown for a little less than 30% of the fetal deaths, while 18% were placental abruption and 14% were fetal anomalies. Next, I looked at the fetal deaths from the maternal care cell. So here I'm looking at the 38 fetal deaths greater than 1,500 grams at delivery. And 45% of the fetal deaths were greater than 37 weeks gestation. The rate per 1,000 fetal deaths and live births is similar in Black and white. And just a reminder that in the maternal health and prematurity cell, the rate was higher in Black births compared to white births. The risk was also more similar across age groups of mothers. And while the risk does decrease slightly as the mother's age increases, this is much more similar than the stark differences we saw in the maternal health cell. I also found that similarly to the maternal health cell, the rate was higher in women with private insurance rather than Medicaid, and it was almost 3 times higher in this group. And over 60% of the causes of death were unknown, which isn't really surprising because a lot of the times you don't know what the cause of death is for fetal deaths. Next, I looked at the infant health cell in the Shreveport area. The infant health cell looks at infants who are born greater than 1,500 grams and who die in that post-neonatal period, so between 28 days and 1 year. And the infant health excess mortality is higher in the Shreveport area than in any other area of the state. The infant health cell accounted for 38% of the excess mortality in the Shreveport area. And if we were to decrease the excess mortality in the cell, we have the potential to avert about 15 infant deaths annually. And the majority of excess mortality is due to sudden unexpected infant death or SUID deaths that occur in the sleep environment. So here's where I broke down the excess mortality cause of death in the Shreveport area. And I found the majority of the excess mortality, almost 80%, were due to SUID or injuries. And in this area, the injuries were specifically homicides. So since the Shreveport area had higher counts than many other regions, I was able to break the PPOR phase 1 analysis down into white births compared to a white reference group and black births compared to a black reference group. And looking at the white reference group, we really aren't seeing that much excess mortality in the Shreveport area. And I just wanted to make a small note that in this pink celled maternal care cell, you see that there's a negative excess mortality. And that shows that the target group actually has less mortality than the reference group of mothers with the best outcomes. Then I looked at Black infants, and I saw that the infant health cell was where most of the excess mortality fell. And this is almost double the excess mortality in white mothers. So it's 2.22 in Black mothers compared to 1.16 in white mothers. I was then interested in what's going on in that green cell. So what is driving this excess mortality in Black infants in the Shreveport area that we're not seeing in white infants? And here I compared the Black infants to the white infants. And the major differences can be seen with the percent of Medicaid deliveries, the percent that lived in urban areas, and the percent that occurred in Bossier or Caddo parishes, which are two of the most populated areas in the Shreveport area. Next, I looked at the neonatal care in the Monroe area. Neonatal care cell focuses on infants who are born greater than 1,500 grams and who die between 0 and 27 days after birth. And the Monroe area had the highest rate of neonatal care excess mortality in the state. The neonatal care cell makes up approximately a fourth of the excess mortality in the Monroe area. And if we can decrease the excess mortality in this cell, there's the potential to avert about 6 infant deaths per year. Unfortunately, we don't have as much information on factors influencing the cell. However, we thought that maybe this could be an opportunity issue. The Monroe area only has one level 3 NICU for the entire region. Therefore, when you look at the number of babies who were born at a level 3 NICU, you found that the Monroe area didn't have enough, and it was much lower than most other regions. So of the babies born between 1,500 and 2,000 grams, only about half were born at a level 3 NICU, when the average for Louisiana as a whole was almost 85%. Of the babies born between 2,000 and 2,500 grams, about a third were born at a level 3 NICU, when the average for Louisiana as a whole was about 3/4. And then of the babies born greater than 2,500 grams, 38% were born at a level 3 NICU, and the average for Louisiana as a whole was about 74%. So looking at the 30 deaths in the cell, the cause of death was congenital or chromosomal anomalies for about a half of the deaths. 55% weighed between 1,500 and 2,500 grams at delivery, which are low birth weight infants. And there was a pretty even split between residents of rural parishes and residents of urban parishes. So in summary, the Houma area had the most excess mortality in the maternal health and maternal care cells. This was due to high number of fetal deaths. However, we saw differences in the type of fetal deaths seen in these two cells. In the maternal health cell, we saw higher rates among Black and younger mothers and those with private insurance deliveries. However, in the maternal care cell, we saw more similar rates by race and maternal age group, while we still saw rates in private insurance deliveries greater than Medicaid deliveries. In the Shreveport area, we had the most excess mortality in the infant health cell, and this was due to excess deaths due to SUID and injury, especially in Black mothers from urban areas. Lastly, the Monroe area had the highest excess mortality in the neonatal care cell, which is potentially an opportunity issue due to only having one level 3 NICU. So now that these analyses are done, we need to think about next steps. Louisiana will need targeted, regionally tailored interventions to address fetal and infant mortality. While I only touched on a few of the regions in this presentation, we could already see that there's big differences between these areas. And we can only imagine that in other areas, we're going to see this too. So while more work needs to be done on what those solutions actually would be, some potential solutions are culturally competent safe sleep education in urban areas in Northwest Louisiana, which is the Shreveport area, or expanding level 3 NICUs in Northeast Louisiana, so that Monroe area. While these are two potential solutions, we should definitely be doing more research on what actual solutions to these issues we may find. So that's all I have for you. Thank you so much for your time. And again, here's my contact information if you have any follow-up questions. Thank you.